Thanks everybody for joining us today for Grand Rounds. Welcome to February. Can't believe the year's already went by really quickly. And happy Lunar New Year to those of you who celebrate that. So enjoy some time celebration with that. But today I'm happy to introduce our guest speaker for today, Dr. Jolion McGreevy from one of our faculty in the emergency department. He's also the medical director there. He also serves on several ethics committees and is here to talk today about a subject that we all work on a daily basis in inspirational first, which is care at the end of life. Thank you, Dr. McGreevy, for coming to visit.
Thanks a lot for having me. So I hope that this is a lively discussion. I don't really have exactly a lecture so much as a couple of things to discuss, and I hope it's robust. I imagine there's sort of a lot of interest in trying to work through some of the challenges here. So we'll see. Just a little bit about my background. I think it's important to have a sense of what my especially moral commitments are on this topic, so you get a sense of where I'm coming from. So I've been here at Mount Sinai since about summertime. I came from Boston, where I worked at Boston Medical Center, which is a pretty large safety net hospital. I was in the emergency department there, and I did a lot of work with the Ethics Consult Service, building it up over a handful of years. From a service that was maybe consulted once a month to one that got probably half a dozen, sometimes a dozen consults a week about many issues, including end of life. I still teach clinical ethics at Harvard in their master's program and kind of do that once a month as well. So I have some sort of connection to ethics still outside of Mount Sinai. Within Mount Sinai, I've joined the ethics committee, and there's some other folks in the room here. I actually want to introduce really quickly Debbie Korzanik, who's from the legal counsel and is also part of the ethics committee and part of this so-called level of care committee, which I'll talk about a little bit, which I also joined about a week or two into coming here to Mount Sinai. Andy Dunn is on that, and maybe some others. And so, as you know, that committee has had a policy for about 2 months, which is currently being called the non-beneficial treatment and level of care escalation policy. And I know it's had a long history over the last 2 years. We've gone through a couple of revisions. The last one was completed about a week or two ago. And so part of it is I just want to dive head into what that policy is about and have a discussion about what works about it, what are some concerns about it, talk about some of the cases that you've experienced, and then also sort of largely talk about it in the context of end-of-life decision-making, especially when you run into ethical dilemmas. So it's a little bit about policy, a little bit about so-called non-beneficial treatment, a lot about how we deal with cases of this sort in a sort of a fair and standardized way. That's kind of the background. So to start with, so sort of objectives. One is to analyze these so-called non-beneficial treatment cases. And then the broader is sort of using clinical ethics and conflict resolution, what I'll call bioethics or clinical ethics mediation, which is a mix of what are the relevant clinical concepts that we need and what are the relevant negotiation skills that we need to try to get some consensus when there are differing values around end of life. And as I mentioned, this issue of non-beneficial intervention is only a small subset of the larger discussion about end of life. And what I want to make sure is that we have sort of consistent language in that entire sphere. So start with the case, and actually we have 2 cases, and these actually probably are your cases that come through this level of care email listserv that when decisions are made, usually with you and RRT about whatever's going to happen, it goes out on a list to the folks on this committee and gets seen. And so I just took the first part of these cases, not a whole lot of detail, but if these happen to be your cases and you want to talk more about it, feel free. If not, we'll talk more broadly. It's not about the case, it's about the larger. So 84-year-old male, history of metastatic colon cancer. Per oncology is not a candidate for any further chemotherapy, comes in with bowel obstruction. Surgery recommends non-operative management, placing an NG tube, decompressing, and see how he does. He's tachycardic in the 180s. He has a lactate of 5. Sounds like got a couple liters of fluid. His lactate is still 5. His tachycardia is still about the same. The patient's son, who's a physician, wants comfort measures. I don't know any of the background on that in terms of what conversations he had with the patient or not. Sounds like he's elsewhere. The patient's daughter says that palliative care goes against everything that she believes in. So this is the case. To start with, I just really want to raise very broad, common sense questions. And starting there, when faced with a case like this, where do you start? Okay. The basic questions are, who decides? Right? This is not a random decision. we have to figure out, first of all, what the question is. Second of all, who decides? What justifies that decision? And what are you going to do when there's disagreement? Okay, so that's the background. So just to starting with the case, and you were to try to get a sense of what the team's question might be, right? Let's say they call RRT, or they call a colleague to say, hey, what do you think I should do? Whatever. What are some questions that are raised in your mind about this scenario?
What are the patient's wishes?
Okay. Other questions?
The patient DNR.
Okay. Does this happen to be anyone's case that they want to say more about? Is recognizable? Just feel free to, not obligated to, but I just, in case people want to know. So, right. So what are the patient's wishes? Do we have any evidence whatsoever pointing to that? Evidence might be in the form of a DNR, right, or some other advanced directive. You could have a MOLST form. Okay, so it sounds like the answer to that is no. And in terms of the patient's wishes, I don't personally know that. I didn't look through the chart. I'm not sure what the wishes were, but these are the key questions. Okay. Okay. And by power of attorney, what you're talking about here is what we would generally call as a healthcare agent or healthcare proxy, sort of the power in that specific realm. And it sounds like no. Let's just assume no, that he has two children, one of whom lives here, one of whom is elsewhere, neither of whom is dedicated as the healthcare agent. Okay. Other questions? And so what you're getting at is sort of what is his ability to make decisions? What are some values and wishes that we might use to make the decisions? So the second question, what is the justification? His values and goals and wishes, to the extent that we know them, is the justification, right? That's ultimately what we're aiming at. So that's a little bit about it. Other realms of questions that you want to start trying to get into.
How unstable is he?
Okay. Yeah, what's going to happen, right? So essentially, what are the clinical facts of the case? I mean, this is a really key point. We're not necessarily that good at prognosticating, often, right? But, it's often said that good facts make good ethics. Really probably the opposite, which is bad facts make bad ethics. I'm not sure that good facts alone make good ethics, but you got to sort out what's going to happen. So it sounds like he's not really responding all that well. So the question obviously is going to be posed, well, he's not responding well to fluid, bolus is on the floor, his lactate is not clearing, his tachycardia is not improving. Should he be upgraded to the step down or to the intensive care? It sounds like one of the children thinks, wants comfort measures, in which case you probably wouldn't do that. The other one says that palliative care goes against everything I believe in. Anything else? Any other comments or things that raise your eyebrows a little bit? Things that you would think about as morally relevant. Okay, so elaborate on that a little bit. What kind of harm are we talking about?
I guess this kind of speaks a little bit to prognosticating in this situation, but if the patient is unstable and not responding, and if we feel that the only intervention that would be meaningful would be surgery, for example, that would possibly cause more harm than benefit. And we kind of leave that at the decision, I guess.
Yeah, great. And so common phrases used to what you're talking about is is the patient suffering? Will he continue to suffer if we do nothing, if we do X, if we do Y? So that's the one point, sort of the pain issue. And then the other is this sort of dignity issue, often is the case where maybe someone is not really experiencing, but you worry that there's some sort of dignity-related suffering, which is a very subjective thing to get into, but I think we know what we're talking about. We're like, God, that state of being doesn't seem to be like something that anybody would want. Well, what about him? I don't know, but it doesn't seem like it.
Comfort withheld is the daughter's belief. What's her experience?
Yeah, and what does she even mean by palliative care? What does she think palliative care is, right? And then why it goes against her beliefs. And what her beliefs about palliative care have to do with whether or not you might intubate the person, right? Or shock the person, or do these other kind of things, right? It's not just palliative care on the one side and then doing surgery on the other side necessarily.
I feel like I'd want to know a lot more about surgery's recommendations, because do they mean they recommend non-operative because they think that could be successful, or do they recommend it because they think they couldn't physically do a surgery that would be helpful, or do they think that they could do a surgery that would be helpful, but he's unlikely to survive the surgery? Like, I think that could mean a lot of different things, and it changes the decision making to know exactly what they're thinking is about that.
My sense, I think a fair assumption is it's a little bit more on the latter, which they feel like either couldn't really do a surgery that would make a difference, / wouldn't survive the surgery. You know, I think with this metastatic cancer, the rest of the history is a bunch of stuff that would make you think it's really not a good surgical candidate once you cut him open. He's not going to do that. That's my sense of that. Right? But the key questions, right? So it's important, all of these questions are the key ones, and you have to structure them in some way so you can figure out what the right questions are, what the options are, and what the sort of moral discussion is about. If you don't have clarity on any of these questions, or is it any of these questions that you've asked, you probably can't make a decision about what to do. You just don't know enough. Right? One sort of quick way of doing this is, what are the medical facts, the medical indications? What are the patient's wishes? What's some comment about sort of the patient's sense of quality of life? And then what is the larger context, social context, family context? That's sort of a quick, kind of little 4-question rubric that gets you through trying to get a lot of that. Anything else that anyone wants to throw out? So it sounds like in this case, I remember this. They decided to keep him full code and that he would be intubated, would get CPR, kind of pending a decision with the family. And it was the son, who's a physician, kind of trying to convince the rest of the family that probably doing a bunch of stuff was really not in his interest. You must have come across these kind of cases all the time. And do you feel like you often get them resolved or resolve them, let's say, in the active sense? Or that they kind of just linger and you don't really feel good about it? That's what I'm trying to get a sense of.
How often do you guys say we come to some consensus with the family and the patient, and how often is it sort of, you don't really get to that level of detail?
Most of the time we come to a consensus between the treating team and the family about a way forward. It's not always easy, and sometimes it's hours and days of back and forth. But I'd say the majority of cases we've come to an agreement. It's rare that I think we've had that discussion and completely opposed with how we should proceed. That's I'd say the majority.
Yeah, I think that's true. Now, one thing we don't have the ones that were an easy consensus where it's obvious don't even enter our denominator. Mm-hmm. So our denominator is patients where like that discussion has to take place. It's not that easy, and you come to some consensus. And I kind of agree with Teddy. Most of the time you do, but then you have patients which are tougher.
Right? My sense is in this vast majority of cases where you're doing just fine, what's happening is you have a good relationship. There's trust. You give a pretty clear prognosis to the extent that you can. You give a recommendation. Right? There was sort of a period of swinging around of decision making where it was paternalism in the 50s and 60s, and then swinging through the 70s and 80s to patients and family members making decisions and sort of autonomy. And then somewhat to the point where people even sort of were reluctant to give recommendations. They're like, well, we can do X or Y or Z, you decide, as if it's like a menu or some sort. Right? I think we're swinging back a little bit to really got to give some advice. And that advice has to be based on the values. My sense is you're doing all those things, which is why the vast majority of cases are just fine. Now the problems, let's say the 5 or 10% or whatever, that are problems, and you feel like you just can't get consensus. What is it about those that you think is challenging? Like, why are you not getting consensus?
A lot of times we have mortality cases are when they've been known to oncologists, for example, and they can we don't have, for instance, with oncology teams or other things like that. So it's us who just have a patient or so. It may look like something percent of life, but then oncologists maybe offer something different. Challenges that they can solve that.
Something that would actually be even sort of an attempt at a curative treatment that may come out of it. Is that right? That's what you're getting at?
Curative or more just for the time.
Other common challenges, things that you think, God, that's a barrier to consensus.
A lot of trust rules on the initial PNR statement because the negative statement in a way do not do something. So a lot of families have the perception that if you change the status to DNR, you automatically say you won't do anything. That means you're giving up on my family, on my person. You know, so I think changing the terminology to something that they use in different countries like Europe, they use allow natural death. So it's a much easier way to understand. And I think when you put it in a different way, families, I think I'm finding it hard to believe that most of the people would ever say, no, I don't want it natural. You know, most people would probably understand it. I think it's just the terminology that we use that can be a little too much in these situations.
I think those are great points, and I sort of implore everyone to make sure you really think through how you're talking about this. This is sort of your bread and butter. I'm sure you're all quite good at this, but the reason you don't send an intern in to do this, it's just not fair to clearly the patient that failed ignores if they're good. Because they'll walk in and say, well, do you want us to like pound on your chest and put you in a breathing tube? It's not what the conversation is about. Obviously, you know, that's a challenge. So you're having, sounds like, pretty robust conversations trying to sort of get the right language.
I think it depends on what you mean by consensus. Because I feel like when you have a consensus, like, yes, everyone understands that this is what the family person wants, but, like, my idea of what might make the most sense or what, like, the most likely outcome would be in either scenario may not necessarily match with what they're requesting. And I feel like one time it's really challenging is if there's just, like, a very strong religious belief or, like, other pre-existing belief system, even if it's not religious, that the person needs to have alive in any way possible. And like I feel like with those discussions, it's very challenging.
How do you reconcile that?
Well, what do you mean by reconcile?
Well, I mean, what do you do? So what do you do and how do you feel about it, I guess?
I mean, I think that there are some families that just, once they tell you they've told you, like, I mean, I think there's members of the Jewish community, there's some members of that community who are okay with changing a flip status, but if it's a religious belief, like, I often don't process, I don't necessarily revisit the conversation over and over again, because it's not necessarily a problem with their understanding of the situation, it's just, so, I don't know, but I think in those situations, this idea like escalating, not escalating, does become really challenging. So say, well, I know what it is to bring this up, and I know like this. I had that with a family. They're like, and I know that this isn't one of them. So like, and I asked you to do everything.
Mm-hmm.
And like, I mean, that's obviously a minority of cases, and then I think there are, I would say, with the consensus, it's also dependent on like at what point the consensus is reached. So sometimes that conversation is ongoing, and then if you wait until the patient gets like sicker, and this person's obviously on their way there, and then sometimes like it's a moment, like RT comes, and then you have another sit down, and then says like, okay, we understand he's really sick. But
What do you think is different? Well, not different, but as that progresses and RT comes, is there a sense that there's something different about that conversation or sort of that moment in time that gets some of these families to say, okay, well, maybe.
so I think sometimes it's not as hypothetical. I mean, like, sometimes a whole bunch of people rush into the room, and I think that looks different. And also, I think these are really scary conversations for families that they have heard probably a lot of the very vivid language that gets used during, like, those care discussions. To the point of, like, okay, now they're pretty soon, they might have to start making some impressions. Like, I had something to say, like, okay, actually, I have not shut up. Like, it becomes less abstract when the person is.
All right. So
Yeah, I just want to make a couple comments. So this may or may not be helpful, but the law requires that decisions be made by surrogates, whether it's a proxy or a surrogate, based on the patient's known wishes, if not known best interest. So even her statement, it goes against everything I believe in. It's really about what the patient believes, and trying to focus the conversation with the son and daughter on what the patient would have wanted. I mean, often we don't know what the patient would have wanted, but to the extent that the family does, or it can be gleaned from how they lived their life or the statements they made, it's helpful to keep the conversation about patient wishes. And then the other point is, so in this case, we have a son and a daughter, so they, under the Family Health Care Decisions Act, they have equal standing in terms of decision making. But there is a hierarchy, so technically if there's a disagreement between the son and, let's say, the sibling of the patient, the son would have priority. But of course, as a practical matter, at the end of life, you don't want to make decisions where family members are in, profound disagreement, even though technically, legally, you could, because the son would have, or the daughter would have authority over other family members on the list. But in this case, they're at the same level of authority, so you want to reach, you have to reach a consensus.
So, in this first little bit, what I essentially wanted to do is just make sure that we're all sort of on the same page and in sort of a common language about how we talk about these common struggles, right? There's no easy solution to the hard ones of these. Like even the ones that get resolved probably are not that easy. We've just gotten really good at them. So that's number one. And so I want to spend the rest of the time really talking through how you work through these. What are some of the key language and concepts that you use? What are some of the things that we should avoid because they're probably pretty confusing? I want to talk a little bit about this law in New York State and how we might interpret that as clinicians. And then talk a little bit about this policy and what it means and what it doesn't. Okay. So, I think the first is exactly as Debbie's saying, if you know anything about this patient's values, then that is your highest guide. That is what you're trying to follow. The rest of it, is subsumed under that. And so that could be a written statement. It could be an oral statement, right? I think for this particular law, the ideal is, an oral statement with a couple witnesses. But really, you're just trying to get a sense of what the patient has said that they want. And two is whether you have a defined healthcare proxy or a surrogate who is a family member or friend and defined in this hierarchy of this law, that they're not acting on things like goes against everything I believe in, right? But rather articulating the reason, the justification in terms of what the patient has believed in and stated. So some key questions are, what have they told you, about XYZ? Have there been any other deaths in your family that they have been sort of made decisions with respect to? And what did they say and what did they use, right? Try to start to do that, and say, if you were in their shoes, what would they say? Or if they were here right now talking to us, what they would say. These are some of the kind of language things to orient people because they don't know, right? They see themselves as, well, I'm here to protect my dad, right? They're not here to protect their dad, at least in the first. They're here to say what their dad probably would say, and comfort may be actually that thing. So that's number one. Now, this law, let me see where I want to put that. So some common phrases. This comes up a lot. So a family will say, we want everything done, right? The first thing is don't ever ask people if they want everything. Everything is not a thing, right? We set that up sometimes. Sometimes families set that up from their experience. Sometimes we set it up. But describe the situation you're in and say, okay, well, this is the prognosis. Here are some of the treatment options. And here's what would be expected in terms of the benefits and burdens to him, the burdens being suffering, dignity, as you can get a sense of it. But don't ever ask about everything because people will always say yes, because otherwise you feel like you're shortchanging. Clinicians will sometimes think or say this is futile. So I want to caution against using that word futile, really ever, because to start with, purely for practical reasons, every family member who has not already thought that themselves hears that as his life is not worth living, it's worthless, we're giving up. Right? They always hear it like that. So it does you no good, right? Now, if a family member or a patient says, I think that would be futile, fine, right? Again, I'd caution you against going too far down that path, but okay, otherwise I wouldn't use it. Two is the philosophical reason, which is futile means sort of meaningless, of no value, but with respect to what? Because if somebody's value is to live for 2 more hours or 24 more hours, or until their daughter arrives on a plane from Canada, then the thing may not be futile. It has nothing to do with their underlying prognosis and whether they're likely to do fine in 6 months or whatever. It's the values we're talking about now. Is it of any benefit or not? And so that's another reason I think to avoid that. Right? You got to talk about benefit and harm with respect to something very specific. We won't give up on my mom, right? Is a common phrase. And why phrasing things like, well, allowing somebody to die naturally or whatever is helps reframe a little bit, right? You're actually giving some permission or even maybe protecting that right if that's a value, but you're not giving up. You're making this difficult decision. And another one is, it's often the case, I don't know if that's here, but where I came from, the teams would be like, we have to have another goals of care discussion with this family. And this would happen like 3 times a week. And what they really meant was, we have to talk to the family to get them to agree with us, right? That's not going to help you either. At some point, the family's like, no more goals of care discussion. I know what these things are, right? So these are some, I think, common pitfalls to be a little careful of because they lead us in the wrong direction. Another one is avoiding words like appropriate. Something is appropriate or not appropriate. Who decides whether something is appropriate? Again, it's the same issue as futile. Based on what values, right? Benefits and burdens is a better language. That too has some subjectivity, but it's not as problematic as futile or appropriate. So this is from 1999, so 20 years ago, from the AMA Council on Ethical and Judicial Affairs. It's in JAMA, and it's sort of a fair process for considering what at the time they were calling futility cases, again, 20 years ago. And I think most hospitals have some withholding or withdrawing policy that roughly follows this. The latter part of it being the point at which is like, this is just not beneficial anymore. But sort of what are the patient's values? Some joint decision-making, bring in consultants, bring in the ethics committee. If you can't reach agreement, you offer another clinician inside, you transfer, so within the institution, you transfer outside of the institution. And if you get to the very, very end, then at some point you stop. Usually that's a decision that you want your CMO support on, right? You don't want individual clinicians like out on a limb doing this kind of stuff. It really should be an institutionally backed decision. And the argument there is at the end of the day, we should not be required to do something to somebody that we think hurts them, is harm to them, even if it's demanded by the family. Let me just say it in the starkest terms, right? And for me, is generally speaking, I feel like the ethical standard is higher than the legal one, meaning that whatever the value is, you have to make sure you're aiming at that value regardless of what the law makes you think you're supposed to do. And often it's the case where the interpretation of law is probably not even right, and why bringing in ethics and bringing in legal and others to sort through that is key, but you can't be obligated to do something that's hurting somebody. Okay. Examples that maybe you've all experienced, but somebody needs dialysis, right? But they're like confused and they're refusing it. They can't really make a decision, but they're refusing. And someone's like, I want you to tie them down and sedate them and dialyze them. Sticking a needle in their arm so they can go flailing around and bleeding everywhere and the pain of that. Is that really something that I should be doing to somebody? That's an example. And I'm sure you can think of many others. Right? So this is a study from California, just of an ethics committee, and basically just sort of talking about their work and qualitatively what some of the process and outcomes were. But essentially, if they had conflicts involving disagreements between clinical teams and families, they would meet and talk to the patient and the surrogate family. If they couldn't reach consensus, they'd have another meeting, bring in another clinician to sort of add some opinion. Third meeting, they brought in ethics, right? This was their process. And then sort of in the end, they kind of wrap it up. That was sort of their process, a few meetings in a row. And they found essentially what you find, which is that, so for them, out of 92 cases in the study, 70 of them were resolved in that first meeting. That's been my experience too, right? They get resolved, which is why everyone in the ICU should have a family meeting within a couple of days, right? Because you want to get on the same page early. About 10 after the second meeting, similar number after that, and only 5, about 5%, were sort of left at the end with no resolution and had to be resolved. So this is pretty good, you know, and I think that involves sort of a robust family meeting and ethics consult and bedside ethics consult process, I would assume. So here's our non-beneficial treatment policy here. And so I want to now go to these end cases of these when there's just no consensus. And I've said, at the end of the day, you can't be forced to do something that's harmful. The tension, obviously, is that, you know, I have a healthcare proxy. I would really rather my healthcare proxy make a decision on my behalf based on our lifetime of conversation than a clinician who knows nothing about it, right? And I think we would all want that, right? We tend to medicalize decisions, tend to pass value judgments that we really have no basis to make. So it's that tension between the two, where we don't want to hurt somebody, do something that's undignified, just because the family's asking us to. We don't want to override surrogates who really are acting in the best interest of the family members. That's the tension. So here's the policy. So treatment or level of care escalation is considered non-beneficial when it's ineffective or harmful. Patients should not be forced to undergo, physicians should not be forced to provide non-beneficial treatments or escalations. It provides some guidance about conflict. And then it applies to the following circumstances. The treatments and or level of care escalation would not result in meaningful survival, or, number 2, would inflict suffering that's highly disproportionate to any likelihood of benefit, right? It's fairly narrow, actually, but leaves a lot of room still for interpretation. So the first question I think you face is, what is a treatment, right? So a lot of times something so let me give you an example. I had a patient in the ER like some number of months ago. Someone here ultimately took that patient as well, who had like, I don't know, a GCS of 3 and was intubated in some sort of facility, and was a young person, came in like, actually maybe they were trach, I think vomiting a bunch of like kind of feculent material. And ultimately, we thought like probably has an ischemic bowel. And stuff was like flying on the wall. He was just sort of doing terrible. Surgery saw him and said, you know, surgery is not indicated, not a good surgical candidate. Right? So the question there that you raise is, well, is surgery for this particular patient in that state, his lactate was like 20 or something, and probably all of his bowel was dead, is that a treatment? Right? It's an intervention. But is it a treatment in the sense that we think is intended to and has some likelihood of helping in a way? Because if it's not, just because it exists doesn't mean you have to do it. So that's the first question. And I actually prefer, if I'm going to talk about non-beneficial something, to use the term non-beneficial intervention. Because often I'm saying it's not even a treatment. Right? And if it is a treatment, then we kind of get into some of these other evaluations. But I think that's number 1. The next is this issue of level of care escalation. By level of care escalation, at least in my view, all we're talking about is location of care. That's a little simplistic, but location of care and, you know, the nursing resources, et cetera. It's not necessarily sort of more or less care, right? And that's where it gets a little bit sticky here, because as you know, you can have someone on the floor getting the pressors, and you can use the pressors, but you can't they're capped, you can't raise them. Right? Policy doesn't exactly talk about those things. This is more general about sort of the decision making, not the policy about the floor. Can the patient get where they are the treatments that you believe are, based on their values, likely to be beneficial? And are there any treatments that they can't get because they're there that would be beneficial based on their values? And if that's the case, then you should change where they are. Right? They shouldn't stay there just because that's our thing. Right? They should go to wherever they get that treatment. Have you heard the term sort of made level of care? You've heard this? So that's another one that makes me nuts. I don't know what that means at all. I have no idea what that means. I've never heard that in my entire life. So I know how it came about, right? What's happening is that we are using a policy to make a designation of patients who are getting different kinds of care on the floor, essentially. But that's what, you should just say that, right? They're on the floor getting care that we think is, you know, kind of matching their benefit. They don't need the ICU to get that care, so fine. They're not being made level of care. You're not designating a different kind of patient. you are in fact using the same kind of ethical decision making that you would for any other patient, and then trying to make a judgment about whether or not they can get the care that they need. But being made level of care isn't a thing, it's just an email list. Right? So I think that's the first thing to try to get out of our lexicon. Obviously, there's a lot more cultural and other challenges about that. And I'm not trying to belittle it, but I think just start there, I think is a good thing. All right, so the policy, sort of our workflow, and it's basically the same as where I came from, where it was under the withholding withdrawing policy. A couple of the Harvard hospitals, Beth Israel and Brigham, I think, both have what was called a futility policy, now it's called a non-beneficial treatment policy, just like this. Theirs has only been used like twice in 10 years, because it really is that very narrow last bit where you can't reach agreement. And ours probably should be, somewhat there in that very narrow thing if you're really using it. So first of all, you're concerned that the intervention is non-beneficial. So step one is a family meeting, or if the disagreement is not between a family and a clinical team, but between two clinical teams, between ROT and the hospitalist, let's say, that gets escalated to the department leadership, right? To try to sort out what should we do. And while we're trying to make some judgments and sort this out, should we do a trial of whatever the thing we're talking about? Should we do a trial of ICU care or something, right? Consider ethics consultation. And, the ideal there is, you get an ethics consult that really helps you walk through some of the things you couldn't get done on your own, and ideally a conversation with the family to really try to help sort through some of those values. That's where it's most effective, let's say. Escalate to the chief medical officer, right? If you get to these very end cases, you need some help do that, because ideally you want support from your leadership. When you're ready to implement a plan, whatever that plan is, hopefully it's a consensus plan, you have to ensure that you have communication and the appropriate resources. If you don't have the right nursing resources on the floor to do the thing, you can't do it. Right? So that's a key part of it. And I think that's part of your decision. And then a daily reevaluation. You make a decision that something is not beneficial. It's not beneficial right now in this moment for this time. It's not. That may not be true tomorrow or 6 hours from now or 2 hours from now. Right? Which is why we really can't be designating patients in a category where they get stuck existing forever, because you're making a decision about an individual treatment in a moment. Does this all make sense, sort of about how you think through this? All right, how about this one? 62-year-old male, history of metastatic colon cancer, complicated hospital course, has recurrent hypotension. He is responding to some fluids and some albumin. The some clinicians believe the patient won't benefit from a higher level of care because of his uncurable underlying disease. Right? So imagine you walk through the same kind of questions you were walking through before. What are your comments and concerns about this case? What would you raise?
His likelihood of self-improvement seems greater than the last patient, where the prognosis was, hours to days of death, and this patient seems potentially able to survive this.
Yeah. Okay. So what would you, if this were your patient, knowing just this, what would be what do you want to do with this patient? Okay.
Perhaps whatever that's what really would be meaningful for him.
Okay.
That's the key to to the patient what benefit would be. So would living 2 weeks longer, right, whether it's in an ICU or hospital or maybe nursing home, would that be benefit for him? Or would that be suffering? And what is benefit?
Great. But it's the same questions each time. You walk yourself through until you get to a part where you're like, okay, well, this is a little different. But yeah, it's the same questions each time. Okay, next. So those are the decision-making questions about the patient values. How about the clinicians? Drilling down into this a little bit, the clinicians' comments.
Again, the wording, the higher level of care, what does that mean? Not necessarily, sometimes not doing things may mean higher level of care, so it's just
Okay.
using that.
I think they're talking about ICU, transfer to the ICU. Yeah, but fair point.
But do they have the same image of what benefit would they be?
Right, and what is their rationale? Their reason is because of an incurable underlying disease. Is that a reason not to put him in whatever place he needs to be to keep getting fluids and monitoring his lactate, and maybe he needs pressors or something, right? Is his incurable underlying disease a contraindication to vasopressors? If it would give him some time that was meaningful to him. It's not obvious to me that that's the case, right? So I think just hearing this, you'd be like, well, that's not really a good statement of the clinical facts and the prognosis and the justification clinically for doing something. That should not be the decision, or at least the justification for the decision, right? You might drill down to, well, there's nothing else that would be done in a different place that would be any different. Fine, that might be a justification, but this one's not. This is a judgment, sort of bringing in a value judgment about sort of his overall trajectory that is not exactly relevant to his current state, not necessarily relevant to his current state. It may be for him, he might say, well, look, this is incurable, I'm not going to live for a bunch, so like, let's just call it or something. He can do that. We probably can't, because we're addressing things far bigger than the question in front of us. Does that make sense?
I guess I would also ask if I see level of care a limited resource in this scenario, because I think that's kind of one of the background
The answer is probably
questions
yes.
that we have, right? And I think that's one of the underlying kind of thoughts in a lot of this decision making. And is it really practical to sort of be parsimonious about that resource in the context of this patient, meaning with putting him in the ICU means someone who needs ICU also, I mean, more, and has more of a chance of meaningful improvement in ICU not getting that resource. And if that's not the case, then can we really think about it?
Do the rest of you have that same thought on a regular basis? Yeah, I mean, everything is so limited. Right? Generally speaking, in the United States, we've been pretty reluctant to make clinical decisions based on rationing. It is really not justification for decisions in the United States. Other countries do this more often. So yes, if you have one bed and you think one patient is going to benefit much more than the other, then yeah, I think it's fair. I mean, I think you really have no choice but to say, I'm going to put that patient in there. I agree with you. On the other hand, sort of in the abstract, what we want to try to be doing is really making these decisions based on that patient. And if we say something is not beneficial, what we're saying is for that patient, based on what we know about them, we think that this is a harm to them. And that's why we're not doing it. It's about them, not the rationing. That's the justification, I think, for this way of thinking, right? And when you start blending the two, it's a little risky. At the same time, you may have to do it if you truly have one.
How often is it not hypothetical? In other words, you're posing hypothetical, but how often are you actually making decisions where it's a rational issue, where you're really deciding between the patients? Is it that limited a resource, or is that?
I would say it's most of the time. Almost every time RT comes and says something about level of care, they will also say there are no beds, or we don't. Like, I think it almost always, in my opinion, feels linked to the availability of ICU beds and emergency beds.
My sense is that's the background. We all know that is a fact, that the ICU level beds are hard to come by. I don't think it usually raises them that explicit for individual patients, at least for me when we're having these types of discussions. It's not that, well, we could bring the patient there, but there's no bed. It's sort of separate than, let's make
I've heard them say it to me on multiple times. I know with other people where they will say, well, there's no beds, or we have someone else that, I've heard them explicitly say it to me.
Yeah, and so this is why we're having this discussion. So I'm meeting with RT tomorrow at 3. Because at the end of the day, we all have to think and talk about this in the same way. And I think the answer needs to be, well, look, the decision that I'm making for this patient, based on what I understand, is that they should be here in X, right? You're the attending of record, right, at the end of the day. The RT is an important guide and a consultant, not the attending of record. You're the attending of record, okay? So you make that decision, and if there's no beds, then at least you're saying, well, the decision should be X. There's no beds, there's no beds. But we're not going to change the decision because there's no beds, right? At least in sort of a not transparent way, right? Because often beds you make a bed, they get made. or RT continues to manage them in the exact same way they would on the floor or whatever. You can't. So what I'm trying to do is avoid sliding into that justification because it's the vague background all the time. Okay, so those are kind of some of our issues. So drilling down into this law, and I'm so very grateful that Debbie is here. So most states, so about 35 or so states, have a law that defines a hierarchy of decision maker when no one is named. Right? So if somebody's name is a proxy or there's a guardian, then that's the decision maker. In the absence of that, about 35 or so states have a hierarchy. They differ by state. In New York, it's spouse or domestic partner, adult child, parent, sibling, something like that in that order, and then friend. Massachusetts has nothing of the sort. Massachusetts is an all healthcare proxy state, and I think that goes back to the 80s and same-sex marriage, and they didn't want to pass a law that would, at the time, make it only spouses that could make these decisions. So there's other reasons why these become a hierarchy. This has come up a couple times in front of the Massachusetts legislature, and they have kind of balked at creating such a hierarchy. But every hospital has that policy regardless, because it kind of matches generally good ethical decision making. That you try to get the person who knows them best, and this is a general hierarchy of who probably knows them best. Right? If it doesn't match, though, my feeling is your obligation is to the patient and their values and following who knows the values the best, not this hierarchy. Right? There you would need some help to sort that out. But I don't think you would follow the hierarchy if the person higher up is not in speaking their interest or doesn't have a good sense of values. You wouldn't do that. Right? Do you agree?
Yeah, I mean, essentially, it's, again, because it's patient's wishes and then unknown best interest, it's about gathering that information. But you could conceivably have, let's say a cousin that they're very close to that actually had the end-of-life conversation with them, but that wouldn't make them the decision maker, but you would still use that information to inform the decision of the decision maker. And if they're not making that decision consistent with what their known wishes are, then you have a problem. But,
and then that problem, you need to get some help with that problem from ethics, from legal. We'll over time keep trying to work on building up resources for everyone to help with that. But I think that's the key. Now, the other one that I've heard in some of these is, well, the healthcare decision, the Family Healthcare Decision Act in New York requires that we do whatever the family says. I've heard this in various, and my read of it is that's not what it says. That in fact what it does is, first of all, the reason for it is to give some clear standing to surrogates who are not already named as a proxy, right? To give them standing, say, well, here's who you would choose. That's the reason for it, so that they can make decisions that the patient would make for themselves. It does, I think, expand the right of that person or the healthcare proxy to make decisions, in that if a clinician refuses to do that intervention that healthcare proxy or that surrogate wants for the patient based on the patient's values, then they need some kind of judicial review or to transfer the patient elsewhere, right? So I think that part is where people are saying, oh, well, at the end of the day, then you have to do whatever the family says. I still don't think that's the right read of that, because first of all, that is, I think, the circumstance where the physician is saying, I don't want to do this, I don't believe in this, right? I don't think it's right. If they're saying, based on what I understand from all of you about the patient's values and what the patient said, I don't think it's right for the patient. So in this case, it's really the patient that is the locus of the values, and the physician is trying to honor that. I don't think that's, I think, the difference. I don't think that's what they mean, right, when they're talking about this. So nowhere in there does that interpret to me that you have to follow what the family says if it contravenes the patient's wishes. Number two, if the patient's wishes are known, because they've said orally or in writing in some way, but even orally with a couple witnesses, so you have some sense of reliability, that they would or wouldn't want X, the surrogate doesn't even really get applied per this law and the way it's written. But you actually would involve them in ethically. But But that person has already spoken for themselves, which is clearly delineated in the law as something that was already said. So again, if they have said, I wouldn't want this, it was very clear, and the family's like, well, I just don't believe in that, I want to, the law does not force you to follow that. Right? You may still you should probably get ethics and legal, et cetera, involved, maybe do a judicial review, et cetera. But it's not forcing you to do the thing that you think is harmful. Does my read seem right?
Yeah, it's interesting, because I never heard anyone interpret it as that law allows you to do. But if people are saying that, then, no, you're right, it does not mean that you have to follow what the family says. The law is very clear, the proxy law also, patient's known wishes if not known best interests. If the family isn't willing to follow that, then you don't follow what the family does, you follow what the patient wanted.
Okay. I think this is key, because at least in one of these cases, I'm not sure, I think that kind of became the conclusion, oh, well, this is what the family said, and so per the law, we had to follow it. And I've seen that a number of times in a number of conversations. Have you heard that before? Okay, I just want to try to debunk that, because I think that you have a lot more ability to do normal ethics. Okay, just wrapping up 2 minutes, any other final comments or questions? I think, yeah.
I found it in certain situations very helpful in people that have their primary care doctors to also involve them in ongoing post care discussions, because they may put a good input into what the patient's wishes are. They can help family. And sometimes it's not just oncologists or patient's primary care doctor that has been seeing patients for a period of time, but that's available. It can be very beneficial.
Agreed. So I'll just end with this slide. So this is there's a lot of nursing literature about moral distress, less among attendings literature, but residents, especially experienced as well. Essentially, moral distress, one definition is you know the right thing to do. I think you know the right thing to do, but you know the right thing to do, and you're prevented from doing it by something, by a hospital law, by a family, whatever. And what that does is it leads to this sort of dissonance and distress, or sort of affront to your own integrity, because you feel like you're not doing the right thing, which resolves a little bit, but often leaves this sort of residue that's kind of now your new baseline for the next incident of more distress, et cetera, to the point where you're just walking around with this baseline distress of, gosh, these cases keep happening. I don't feel like I'm getting resolution. You can't let that happen. And if you're seeing this in your colleagues, you can't let it happen, which is why I think we need to sort of build up more robust conversations about this stuff. So they're always using the right language, recognizing when there's issues, following a consistent process for working through it, asking for help, et cetera. So this is really just a first conversation at this. Hopefully we'll do more over time, RT and others in you, but raise stuff as you can.
So I think this is a great slide, and I think it's true. It's obviously a big challenge and stress to the clinicians, the hospitals who see so many of these patients all the time, and RT as well. I think when the services work well together, whether it's RT and the hospitalist or ED, and et cetera, it sort of puts this in context, and sort of gives you a little bit of purpose and meaning that you're doing something right, ultimately. And the opposite's also true. When people feel like they can't come to consensus in a way that's collegial, the communication isn't as good as it could be, it's also a bit demoralizing. So I think that I'm very, very happy and glad that you're sort of part of these discussions. I've been meeting with Rupert also, ways we can work better together. So I think that will just make the communication process ultimately better. There's more work we can do there.
Okay, thank you so much for your time. It was a pleasure.